I just wanted to talk about our, I guess, philosophy and goals for you guys to get out of this lecture series. So anatomy is a crucial part of medicine. Obviously, a lot of people would probably know. And what we want you guys to do is make sure you connect the anatomy to the physiology. To be fair, we really can't dive that much into the physiology due to time constraints, but we will try to sprinkle in the physiology so that it's a lot easier for you guys to understand the anatomy. Also, we'll be sprinkling in some cases, like mini cases, so that you guys can connect the anatomy and a little bit of physiology to a more clinical aspect. Also, one thing is you probably won't see a lot of words on the slides. That's because this is anatomy, and as our professors say, try to feel with your eyes. So instead of reading, you guys know pictures do justice more than 1,000 words. So just try to focus on the image, listen to what we are saying. We'll try to take you guys step by step in terms of describing what's going on. So definitely try to take notes. We do have some notes filled out in the bottom section of the slide. So use that as reference. Try to take some notes that we talk about, but really just try to focus on what we're saying and on the image itself. Does that sound good to everyone? Just checking. All right, cool. So we'll dive right in now. So week 2, pulmonary structure. These are the goals that we have for everyone. Understand the structure of the pulmonary system and its relationships within the chest cavity. Relate surface anatomy landmarks of the thorax to underlying pulmonary and pleural structures, and identify basic structures of the pulmonary system in imaging studies. Next slide, please. So for today's lecture, I'll be getting started off, and then Morgan will be transitioning. I'll be kind of starting with the outer parts of the body, going in towards the lungs. So we're going to be starting off with the chest wall. I'm sure everybody heard of the term chest wall, but can people tell me what's composing or what's comprised in the chest wall? I'm checking out the chat right now. Intercostal muscles, nice. Skin, muscle, ribs. Sternum is definitely part of the bony structure in the chest wall. I like that. So pleural we'll be talking about later, but it's technically not part of the chest wall. So this diagram may be a little misleading. Fat is definitely a big part of it. Subcutaneous fat is a huge component. And yeah, blood vessels. Yeah, I see a lot of people writing down good answers, but the general idea is that there's skin in the very most outer part that you can see right here. There's a superficial fascia, aka fat. There are the ribs, and there are different muscles of layers. And the 3 important parts that we really have to know are veins, arteries, and nerves that run along the ribs. So these are the veins and arteries that help with the blood flow in the chest wall, and the nerves that help move and sense the chest wall. So this is a general diagram, just zoomed in on the right diagram, and I hope everyone can kind of visualize what type of section this is that's taken from the image. Any questions for now? I guess we're good. Yeah, so next, this is the general landmark of a real human with the ribs overlaid. So a general idea with the ribs, there are 12 of them, as a lot of people may know. And it's divided into true, false, and floating. And one way for you to memorize which ones are which is you want to first know that the 1st to 7th ribs are the true ribs. These are the classic ribs that you can feel in the front part of your body. 8, 9, and 10 are the false ribs. And one way I try to memorize this is that 7, 8, as in the past tense of eat, 9 and 10. So you would see 8, 9, and 10 ribs kind of attached under rib 7. Can everybody see that in the image? I'm checking the chat. Please answer. Perfect, thanks. And then the 2 ribs that you don't see here, which ones would you say they are? I told you guys there are 12. So 11 and 12, perfect. So yeah, that should be in the back part, attached more to the vertebrae, not in the sternum. Yep, so those are the floating ribs. So speaking of sternum, we see that, so the entire sternum is the three bones right here in the middle, and it's divided into three different parts. There's the manubrium, there's the body of sternum, and the xiphoid process. A lot of people may have been familiar with these terms. So the manubrium is like the shield. So it kind of looks like a shield that you can feel right here in the top. And that's connected to the body of sternum at rib cage number 2. And the xiphoid process, it's like the very pointy process in the very bottom part attached to the body of sternum. And that's something you could feel once you try to press down on the non-rib area, and you can feel up, and that should be the xiphoid process. It's a pretty delicate process. And one important thing right here is the sternal angle. So the sternal angle is right when the manubrium and the body of sternum meet. It's exactly at rib cage number 2. And it's also called the angle of Louis. So the angle of Louis, the way I kind of memorize this is I think of like the French Revolution, and the Louis XIV. And I obviously know they didn't fight with shields and spears, but I kind of imagine a soldier named Louis kind of holding a shield and having a sphere right under it. So you see the xiphoid process is like the spearhead going down, and the manubrium is kind of like the shield that they're holding. And I hope that's helpful for people to kind of memorize this different landmarks. One thing in medicine and anatomy is figuring out ways that can help you visualize and just memorize certain things. So I really encourage everyone to try to come up with their own ways to just kind of help you guys memorize and understand and visualize the anatomy. And it could be like any fun way that the more creative it is, the better you'll understand. So just try to be as creative and personal as possible when you try to memorize these processes. Next. So we're going to start off with the vasculature of the chest wall. There is obviously the arteries and the veins. We're going to be getting started off with the arteries. So I want people to first get oriented with the image. So we have the rib cages, the manubrium, the sternum, and the xiphoid. And on the right, I just have an image of the aorta, and I'll be talking about why that's kind of important. So the vasculature in the chest wall is basically divided into anterior and posterior. So I know Madison and Ben went over all the anatomical terms, but in layman's terms, can somebody tell me what the anterior side would be? So is it the front, back, top, bottom? So it's the front, that's perfect. And the posterior would obviously be back, perfect. I just wanted to make sure. So we will be using anatomical terms from now on. I know you guys are all masters of anatomical terms at this point. So let's try to get used to that. It's the only thing people in medicine and science really use. So it's best to get accustomed to that as early as possible. So the posterior circulation of the chest wall is mainly supplied by the descending aorta. And I don't know if people really studied the heart and the circulatory system, but it's basically the main aorta that branches off the heart. So we'll be touching on the heart and circulation next week, but if I were to give a brief preview, we have the heart, and the left ventricle is where all of the blood is really being pushed out from the heart. It's the main muscle of the heart that pumps blood out. The blood is then going to travel to the ascending aorta. So I'm kind of looking at the right image right here, and then go to the arch of aorta, and then the descending aorta. So once you see the descending aorta, you can see on the left image this huge thick tube that's running along the vertebrae. Morgan, can you kind of show, pinpoint on the left image? So you see that huge tube. Can everybody see that running along the left side of the vertebrae? I'm trying to see feedback. Perfect. You guys really have to be engaging. It helps me going, and it's also just more fun. So perfect. So you see those little branches coming off the descending aorta right next to the vertebrae. So those are the posterior intercostal arteries. So one thing to know in anatomy, especially medical anatomy, a lot of the names make sense. And if you put them together, they should make perfect sense to you. So posterior, obviously it's on the posterior side of the chest wall. Intercostal, so costal basically means rib cages and the ribs. So it's intercostal, meaning it's going side by side with the ribs, and it's an artery. So posterior intercostal artery. So if I were to tell you guys that, you guys should be able to say it's going to be supplying the posterior part of the chest wall. It runs along the ribs, and it's an artery. So it's basically supplying blood. So the big difference between arteries and veins, arteries, in simple terms, it's supplying the blood, supplying the oxygen, because blood carries oxygen. And the veins, it basically carries back the deoxygenated bloods. So once the arteries supply the tissue of oxygen with the blood, the oxygen leaves the blood, and the deoxygenated blood is going to travel through the veins, which I'm going to talk about in the next slide, and it be drained back in. Does that make sense? So I'm seeing some questions here. So descending artery goes along the backside of the ribs and chest wall. So it's basically running along, you can see in the image right here, it's running along the vertebrae. So the main descending aorta is basically traveling along the left side of the vertebrae. Yeah, sorry, the chat's kind of overwhelming, so I'm just making sure I address everyone's questions. It's a little laggy. Perfect. I think we're all set. So any other questions about this slide? Does descending aorta leads blood to foot? So eventually it will, but it obviously is going to branch off into different arteries before it reaches the foot. So technically the blood will travel through the descending aorta before it reaches the foot, but it's not directly supplying the foot, if that makes sense. We're going to be talking about more circulation throughout the courses, so I wouldn't get too worried about the other parts of the body and how it's applied, and just try to focus on the chest wall, because once you establish this, every other system that comes along is going to be a lot easier for you to understand. So one thing about anatomy is that the human body is very well conserved in different parts of the body. So once you start picking up these ideas and just the way things work, you can apply this to other parts of the body, and it will be a lot easier for everyone to learn. So what is the name of the place where the aorta goes through the diaphragm? So we're going to have a slide on the diaphragm, so just hang tight on that question. Memorize every major blood vessel. So there are major blood vessels that you do have to know. The ones in the slides are pretty important high yield arteries that you should know, but do keep in mind this is from like basically the medical anatomy course that we're currently learning as current students. So for people who are planning on going into medicine, any healthcare, you guys are going to have a course, trust me, to learn all this. So we kind of want our summer series to just prime you and just be more familiar with all the blood vessels and the different parts of the body, but not necessarily memorize every part. So try to focus more on the big concept ideas, how things are organized, and how things and the way and the reason why things are organized a certain way. All right, so I think we're ready to move on to this slide. So this is the veins basically draining the chest wall. It looks a little different. Can I actually go back a slide, Morgan? So if we look at the aorta, the right side right here, there's one thing people would probably notice branching off the arch of aorta. Can people just write in the chat what they kind of notice here? Yep, you see arteries. But an interesting thing here is that the right side and the left side is not symmetrical. So if you see right here, there's a brachiocephalic artery on the right side of the arch of aorta. And in the picture, it's the left, but you got to realize this is facing us. The patient or the person is facing us. So their left is the actual right. Or so the left we see is their right. Does that make sense? So you see the right part having a brachiocephalic artery as a thicker tube or thicker artery before it bifurcates, meaning it branches off into two, to the right common carotid artery and the right subclavian artery. However, the left side of the patient, it has the left common carotid artery directly branches off the arch of aorta, and the left subclavian artery branches directly off the arch of aorta. Do people see that? This is actually a very important concept for people to understand. So once the blood leaves the left ventricle, goes up to the ascending aorta, goes to the arch of aorta, so blood can either go to the descending aorta and then supply all the structures below, but it also has to supply the head. And the way it supplies the head, it has to go left and right. For the right side, it goes to the brachiocephalic and then bifurcates to the right subclavian and the right common carotid, while the left side, it goes directly to the left common carotid and the left subclavian. Subclavian means right below the clavicle. So sub meaning below the clavicle. And the clavicle is the collarbone that a lot of people probably may have heard of. So just keep that in mind. Why is it like that? It's just embryological, just rule of law. I guess that didn't make sense. The rule of science. It's just something that we have to accept. Is the brachiocephalic there because the arch isn't midline? So the brachiocephalic reaches over to the right. So the brachiocephalic only exists on the right side. So yes, it's mainly supplying the right side. For time's sake, we're going to be moving on. So this is the veins. So the first thing I want you guys to notice is that the veins actually have both left and right brachiocephalic. So this part is a little symmetrical. However, once you go below, it's going to be a little complicated. So it's going to be very different from the arteries. So the general idea is that the anterior and the posterior, it's divided that way. The anterior part is similar to the arteries on how it's organized. However, the posterior part is where we should kind of look at it and it gets really funky. So the posterior part drainage is basically divided, how it's drained is divided by the level of the rib cage. So the first veins from the rib cage drains directly in to the left, the brachiocephalic veins, both left and right. First posterior intercostal veins drain into the brachiocephalic vein. I want to make that clear. So the first level, both drain into their respective, so the left posterior intercostal vein will drain into the left brachiocephalic vein, and the right posterior brachiocephalic vein will drain into the right brachiocephalic vein, or right posterior intercostal vein will drain into the right brachiocephalic vein. Is that clear? That's a very, very high yield point. And on the right side is easy. You see the big circle on the right side, or the picture's left in the diagram. The picture's left, so the right side, Morgan? No, the right of the patient. I'm looking at the yellow, yellow circle right there. So everything from the second posterior intercostal vein all the way up to the 11th intercostal vein, it's going to drain into the azygos vein. And the azygos vein is that long string that you see right there, and that's eventually going to drain into the inferior vena cava, which is where most veins drain into before it reaches the heart. Does that make sense? Can you go back, please? And on the left of the patient, so the left posterior intercostal veins, from levels 2 to 4, or normally 2 to 4, it will drain into the accessory hemiazygos vein, which is on the left side, and that will drain into the azygos vein before it drains into IVC. And everything below that, so everything from 5 till 11, it's going to drain into the hemiazygos vein, drain into azygos vein, and into the IVC. So the big picture idea here, the right side of the posterior intercostal veins will drain into the azygos vein before it drains into the IVC, and always consider the IVC, inferior vena cava, to be the ultimate draining spot before it drains into the heart. I'm seeing a lot of pictures about the Google Drive. I'm hoping other people can address that and everybody can access the files. Yeah, and back to the lecture. The left side, the hemiazygos veins are more for the top parts of the left posterior intercostal veins, which all drain into the azygos before it drains into the inferior vena cava, along with the accessory hemiazygos veins. So everything will drain into the azygos before it drains into the IVC. It's just a matter of what does it reach before it does. So even after this session, I want people to kind of look at the images and just really visualize it in their mind and have a mental image of how this is working for both the arteries and the veins. Are the hemiazygos veins specific to the left side? Yes. So it's responsible for the bottom left rib cages, posterior bottom left rib cages. And I forgot to talk about the anterior portion. So can we go back a slide real quick, Morgan? So the anterior portion is much simpler. So you have these internal thoracic arteries that branch off to subclavian arteries. So I talked about the subclavian arteries. So you have a left subclavian artery and a right subclavian artery right below the clavicle. And there's a long string that basically comes down called the internal thoracic artery. And the respective intercostal, the anterior intercostal arteries would be branching off the internal thoracic arteries. Does that make sense? And if you go right, or if you go forward a slide, Morgan, thank you. It's gonna, I don't have it in the diagram, but it's gonna be the exact same for the veins. So the anterior intercostal veins will drain into the internal thoracic vein, drain into the brachiocephalic vein, and then go into the heart. Does that make sense? Can people write yes or cool or it's confusing? All right, perfect. Yes. So we can move on. We're a little short on time, so I'll try to speed things along. So we have our first case here. Patient presents to the emergency department with severe shortness of breath. So the person is obviously not being able to breathe very well. And there's right-sided chest pain. The attending orders a CT and chest X-ray. So we see 2 X-ray images on the right, 2 CT images on the right. So they're not paired accordingly. So I want you guys to kind of think and pair which X-ray belongs to which CT. So for example, the bottom left would work with the bottom right and so forth. So I want people to think about it a little bit. So Adam wrote top left, bottom right. So I'm seeing a lot of top left, bottom right. Perfect. So people have, I'm assuming, a general idea of what they see. So if we look at the X-ray right now, we see the bottom part of the right lung, the patient's right lung, pretty much opaque. We call this radiopaque because this is a radiograph. So if you see the left lung, that's pretty much a normal lung. You're supposed to see just dark, because it's air, it's more filled with air, and little branches of the vasculature. But on the right side, you see that there's a huge chunk that's just very opaque. And can people tell me why? Oh, Maha asked, why is it opaque? So can people tell me why it could possibly be opaque? Fluid, pleural effusion, perfect, Emma. Pneumonia can definitely be something that makes it opaque, fluid in the lungs. So yeah, so any sort of thing that makes it more fluid-like or solid-like, it's gonna appear more opaque. But for us to figure out, is it fluid versus just actual consolidation, it's gonna be hard to tell in an X-ray. So in the CT scan, we're gonna just look through this very quickly. So the bottom right, this is a transverse cut, and you see the vertebrae like facing down. So you can see the patient is basically laying down with head facing the roof. And you see the dorsal side being filled with fluid on the right lung. Can people see that? There's huge grayness. So the left lung is supposed to be pitch black, but on the right side, you see that just grayness. Consolidation means when it's just solidifying. It's another word for solidifying. So the top left and the bottom right are matched, and the bottom left and the top right are just completely normal images. So bottom left is a normal chest x-ray, and the top right is a normal CT scan. So that's for your reference to kind of compare the pathological scans. So we have an idea that the top left and the bottom right could be our patients. Can we go forward? So we got to take this fluid out from the space. And since if you have a bunch of fluid build up there, your lungs can't really expand and contract for good air movement into our body. So a procedure that a lot of emergency doctors use, it's called a chest tube placement. So what they do is they make a tiny hole between the ribs and basically physically drain out the fluid. So obviously we're not here to become emergency doctors, but this is a basic diagram of what's going on. And you try to place this in, it's called this safety of, triangle of safety. And that's shown in the very bottom right diagram. Here it's not a triangle, it's more of like a rectangle, but that is like the safe zone where you wouldn't necessarily hit important structures such as blood vessels, nerves, and veins. But here is a quick higher order question is, the attending asks you to place a chest tube to drain the fluid. Where would you place the needle? And these are the answer choices. Morgan, do you mind going back to the first slide or the second slide, I believe? So if we look at the left image here, this is the way the ribs are organized. I want you guys to really understand this image. And if you were to choose, so imagine this place is right where the triangle of safety is. Try placing a needle somewhere in this image and try to tell me where you would be putting it. So I'm seeing a lot of answers. Can we go back to the answer choices, Morgan? So I'm seeing a lot of C, midway between the ribs. I'm seeing some A's above the rib. So the answer is actually right above the rib, but I'm happy that people wrote midway between the ribs, because in an ideal ER setting, that would be the safest place for you to place the needle. The only thing is it's not as practical because it's kind of hard to find right between the two ribs. If you feel your ribs, it's a pretty narrow structure. So finding right in the middle of it is a little difficult, especially when you're in an emergency situation. So one thing you want to do is feel the ribs, feel the top boundary of the rib, and try to place a needle right there. And the reason being, vasculature and nerves, the important vasculature and the nerves run under the ribs. So the intercostal veins, intercostal arteries, and the intercostal nerves run along the bottom part of the rib. Can we go back to the picture, Morgan? So you see right here, one way to memorize is it's organized VAN. So the veins, arteries, and nerves. So imagine van, it's running along the ribs. So there's a van running along the ribs, and it's because from superior to inferior, it's vein, artery, and nerve. And that's right below, so you want to be able to feel the upper part of the ribs to avoid hitting these vein, arteries, and nerves when you place the needle. And I'm sure people are asking, what about the collateral branches? Are they not important? For our sake, it's not. So if we had to choose, we would rather damage the collateral branches when we place the needle and not the intercostal vein, artery, and nerves. And I think we should move along. This is having too much fun. Time's really flying. So this is the little bit of physiology that we want you guys to understand. So air comes into the lungs when there's negative pressure in the lungs. So one thing you have to realize is air loves to travel. It's basically the principle of diffusion. Air would like to travel when there's lower pressure. So what we're doing is we're artificially creating negative pressure in our body so that air would naturally travel through our mouth or our nose to go into the lungs. Does that make sense? So we're going to be talking about the specifics with Morgan because she's going to be talking about the respiratory system. But basically, the whole point of the chest wall is that it's expanding and making space for arteries to come in. So you see the red arrows is during inspiration when the chest wall is expanding, and the blue arrows is what will happen when we're trying to expire air. So we want to contract the space so that air can actually leave our body. Does that make sense? So what would happen if the needle accidentally touches the VAN? Not good. We don't want to think about it. That's the last thing you want to really do. But literally what would happen? So you're cutting off the arteries. So that portion of tissue wouldn't be able to get oxygenated blood, first of all. And if you damage the nerves, you would lose sensation. You wouldn't be able to expand that rib cage or I'll be talking about that in the next slide. But yeah, a lot of not good. It's not good. So you definitely want to avoid hitting VAN. And that's for any surgical procedure. A lot of surgery, the whole idea is how do I not hit the arteries, veins, and nerves and be able to do what I do? So for example, if you're taking out a tumor, how can I not hit the arteries, veins, and nerves surrounding the tumor and keep the patient basically safe while I take this tumor out? That is a huge high yield point that I want people to know when they're going into medicine. Can we move on, please? So these are the intercostal muscles. There are two intercostal muscles that I want people to really understand, and it's 1 and 2 in the image right here. So the 1 is the external intercostal muscle. So it's not too fancy. It's just on the very outer part. So it's called external intercostal muscle. And 2, I'm going to lump 2 and 2A together. 2 is the inner intercostal muscle. And the way these move, the external intercostal muscle is the one really responsible for inspiration, AKA kind of making space for air to come in. And on the right side, you can see the diagram of a pump handle and a bucket handle. And this is literally just the way these muscles help the rib cage. So obviously rib cages can't move by themselves. They're just bone. So how these move are through these intercostal muscles. So the external intercostal muscles basically help ribs move outward and upward. Let's see. So what about patients that have a lot of fat tissue on their chest? I'm a little confused by the question. Even if there's a lot of fat, you will still just puncture through, and you want to be able to go through all the layers and reach the pleural cavity to drain the fluid out. We're going to be moving on. So next slide, please. So this diagram, I'm not going to go too much into detail. There's a lot of information, but I want you guys to kind of sit down and just check them out after the session. The general idea is that there's a difference between forced breathing and relaxed breathing. During the relaxed breathing is just everything that people do when they're just staying still. So during inspiration, when air is coming in, the main muscles that are used are the diaphragm that contracts and the external intercostal muscles. So again, the diaphragm contracts downward to create more space, and the external intercostal muscles move the ribs outward and upward to also help create that space. Does that make sense? When you're trying to do forced inspiration, so not normal inspiration, but when you're trying to take a deep breath in, like I actually want everybody to kind of take a deep breath in and feel the muscles that they're using. So when you take a deep breath in, you feel your rib cages expand. So that's the intercostal muscles. And you should also feel a little bit from your neck. So when you take a deep breath, you would feel this huge chunk of muscle right here. So those are the accessory muscles that are also shown in the diagram. And that's composed of the sternocleidomastoid and the scalene muscles. We don't have to go too much into detail, but just recognize that the accessory muscles, aka the neck muscles, help during forced inspiration. And when you're breathing out, it's a very passive process. So the diaphragm is going to be relaxing. It's not contracting. So it's relaxing, coming back to its normal form to reduce the size of the chest wall and the chest cavity. But if you want to force breathe, if you want to blow a candle out, for an example, and breathe out, you're also using your abdominal muscle and the internal intercostal muscle. So you remember that muscle right underneath the external intercostal muscle? That's going to be helping you breathe out when you're forcefully breathing out. So those are the general big picture ideas that you want to have, is the difference between relaxed and forced breathing and the different muscles used. And this should all be in the notes in the Google Drive. I hope everyone was able to find a Google Drive by this point. So make sure you go through that, and try to keep that in your head. Try to do the breathing exercises and feel the muscles that you're using. This is honestly the easiest way to learn. I'm going to be moving on. So this is the diaphragm. In its normal state, it's kind of curved in that C shape. And once it contracts, it's going to kind of flap downwards and become more flat. And that's how it creates more space. And I know people were asking about how the different structures go through the diaphragm. If you see here, there are 3 different hiatus. For the sake of time, we can't go through them in too much detail right now, but like the esophagus, the descending aorta, the IVC, all pass through these different holes. And this should all also be in the notes. So case number 2, really quickly. A patient presents to the clinic with shortness of breath and occasional right-sided chest pain. So the attending, again, orders a CT and a chest x-ray. What is going on? So I'm going to just dive straight into it. Once you see right here on the x-ray is that the right side, so normally when you take an x-ray, I don't know if people took chest x-rays, but the radiologist would tell you to take a deep breath. And you see here that the person probably took a deep breath and the left side is contracted, so the diaphragm was able to contract, but the right side couldn't. So this person physically cannot contract the right diaphragm. So can we move along a slide? Oh, actually, yeah, we can just go back. And the reason why is the diaphragm is innervated by something called the phrenic nerve. It's actually really important because it's the nerve that branches off the cervical spine that basically controls your diaphragm. So it tells the diaphragm to contract. And there's a left and a right phrenic nerve. So for this patient, the left phrenic nerve is obviously working because the diaphragm was able to contract. But the right phrenic nerve isn't working for some reason. There are a lot of different reasons why it may not work, but it's not working. So even if the patient is the brain is trying to tell the right diaphragm to contract, it physically cannot because the nerve is damaged. And this is what you can see through the x-ray and the CT. And this is from the same exact patient, so you could kind of overlay them and see what's going on. And we're gonna move along. So we wanna talk about the pleural cavity very quickly. These are basically spaces that encapsulate the lungs. And they have 2 different layers, the visceral pleura and the parietal pleura. The term visceral and parietal is gonna be used very much like the whole time for every organ system. So try to memorize those 2 terms. Visceral meaning right next to the actual organ, parietal meaning just around that organ. So these are the 2 layers. The visceral one is going to be the one overlaying the actual lungs directly, and the parietal pleura is just right outside of that. And when we're talking about the pleural effusion, and when we say fluid is building up, it's building up between the visceral and the parietal pleura. That's a very important point. So I'm going to say this again. When there's an effusion in the lungs, so a pleural effusion, this is when, for some reason, there's fluid building up in between the visceral pleura and the parietal pleura. And this fluid could be blood, different pleural, just fluid that helps lubricate the lungs, because you don't want too much friction when the lungs moving, contracting and expanding. So there's a lot of lubrication that goes on. So these kind of fluids can build up and cause a pleural effusion. And the left diagram just kind of gives you a more realistic diagram of how it's really organized. So imagine your hand is the lung, or your fist is a lung, and you're pressing against a balloon. It's going to form 2 different layers. And the very outer layer is the parietal pleura, and the inner layer is the visceral pleura. We'll move forward. And this is just for you guys to feel with your eyes. This is one of those diagrams I want everyone to feel with your eyes. You see the kind of thin layer of the pleura surrounding the lungs. And the green layer is something we'll be talking about next week, and that's the mediastinum. So that's a little preview for next week. And we can move along. And this is just a diagram for everyone to kind of check out after this session, to kind of sit down and really understand how the pleura is organized, since the pleura is also divided into different layers depending on which side it's touching, such as the diaphragm, the mediastinum, the costal, and so forth. So that's one thing I want you guys to kind of check out. And yeah, I'll pass it off to Morgan.
Hey guys. All right, so we are going to start talking about the lungs themselves. So on the left, we have a microscopic image of an alveoli. And basically what I want you guys to take from this is connect the overall goal of the lungs. So the overall goal is to oxygenate blood. And in order to do that, we need a lot of surface area to allow for diffusion. So we need a lot of air coming in, and then you can see it comes into these little, basically these little bubbles called alveoli. And those alveoli are surrounded by capillaries, which are very, very thin-walled vessels, which allows all of the oxygenation to go right into the blood. So basically, if you look here on the right, you see this like soft, pink, spongy tissue. And that's how a lung is supposed to look. And it's supposed to be, it's filled with air, it's supposed to be very vascularized, and just very like spongy looking. And then we see on the bottom here, we have a smoker's lung where you can see kind of buildup of toxins, and they're just not looking great. So that's the overall microscopic view. And we're gonna look more macroscopically because that's more physiologic, but just anatomically understand that this is what's going on within a microscopic level of the lungs. Okay, so we have, this is just a diagram of the two lungs. So do you guys know, can someone kind of try and orient me to what side my mouse is on right now? Can you guys see my mouse? Okay, it's the left side, but when it's the left lung, but are we looking at the anterior portion or the posterior portion of the patient? Okay, so anterior is correct. So we're kind of looking at the lung right now as if you're looking from the middle out. So we're looking from medial to lateral. So you can see here we have, this is called a hilum. And the hilum is, you think of lungs as trees, the hilum is the trunk of the tree. So that's where all of the blood and all of the oxygen is going to come in through. And you have, here you have the pulmonary arteries, you have bronchi, and you have the pulmonary veins. And so it's going to come in there. So we're looking as if we were looking from the heart out. So this is where the heart would sit, right here. And this is anterior, and this is posterior. So this is where your vertebrae would be, and then this part is what runs along the ribs. So you can see kind of what Brendan was talking about. There's a lot of asymmetry here. So it's pretty interesting. So the right lung, the biggest thing that you probably will be able to notice is that the right lung has 3 lobes compared to the left lung that has 2 lobes. And you can see these lobes are divided by fissures. So you have your oblique fissures, and oblique fissure is on both left and right lung. And then on the right lung, you have horizontal fissure, which separates the superior and the middle lobe of the right lung. And that's the one that's not on the left lung. So you have 3 lobes in the right lung, 2 lobes in the left lung, superior and inferior in both of them, and then the middle lung is only in the right lung. The middle lobe is only in the right lung. Does that make sense, everyone? And what do you guys think would be sitting right here where my mouse is? I think I might go out. Yeah, so this is going to be the diaphragm that's going to be sitting right here. You can see that, like Brian was talking about, it's kind of like ballooning upwards, so you can see the concave surface of the bottom lung. So that's how you can tell that it's the inferior portion. and the inferior portion of the lung is called the base, and the superior portion, which is here, is called the apex. So just general anatomical terms, you know, so if someone's looking at the apex of the lung, they're looking more superiorly to the cervical area of the lung. So this is just a little layout for you guys about how they do chest x-rays. So chest x-rays are super common. They're very easy to do. And so they're done a lot. So when we're referring to a chest x-ray, they're either AP or PA. Does anyone know what those stand for? Okay, so yeah, so AP is looking from anterior to posterior, and PA is looking from posterior to anterior. And you can kind of see how they do the PA view down here. Whoops. So you have the patient stand up, you have them twist their shoulders out so that you can get a better view of the lungs without the scapula in. The scapula are kind of the bones on the back of your shoulders. And so you're really like pressing out your scapula so that they don't get in the way of the x-ray. And you can see it really open up the lungs, and you can see that the clavicles too are pulled kind of up and out. And so for the lungs, PA is really the ideal way to look at the lungs, because in the AP image that you can see, the heart looks a little widened and it's a little enlarged, and you just don't really get a great view. So the only time they really use an AP view is with like if the patient can't stand up. So you will have them laying down on this too. Can you guys hear me okay? Hey, Brian, can you hear me?
Yeah, I can hear you. I can hear you. Yeah, so I think since we have 1,500 participants, it's a little too much training for med students. Wi-Fi, we can't afford fast Wi-Fi.
Let me know if you guys need me to repeat anything.
Try to bear with us.
If you need me to repeat anything, just let me know. All right. So we have case number 3 for this lecture. ML is a 64-year-old woman presenting with a history of cough and wheezing for the past 5 days. The cough is productive with yellow sputum. She is presenting with progressively worsening shortness of breath, and she thought this was due to a cold, but it is getting much worse. Okay, so based off of what you guys know about the anatomy so far, and specifically about the diagram of the lungs that I showed you. So you're gonna look at these 2 x-rays and try and pinpoint where exactly the problem is in the lungs. Oops. Can you guys hear me? Hey, Brennan, can you hear me?
Yeah, I think people are they're saying right lung.
Right lung? Okay, I can't really see the chat. If you want to moderate.
So they're saying right lung, right lung at the bottom. So
at the bottom, okay.
Good job, guys.
Yeah, that's great. So if you had to pinpoint a lobe, which do you think it would be in?
So people are saying right lower lobe.
Okay, so I'm just gonna,
right lung.
I'm going to back up to right here. So we're seeing a cross section here, and there's a consolidation, which is the opaqueness. And so the tricky thing about x-rays is that they're a 2D image of a 3D structure. So you can't necessarily tell where the problem is just based off of the x-ray. So if we look here, it could either be in the middle lobe or the inferior lobe. So that's why we are going to need another view from the x-ray of a lateral view. So we're going to add that in here. So now what do you guys think?
Yep. So Fatima said middle. Some people are saying inferior.
Okay.
Caitlin said middle. Laura said middle.
Yeah, awesome. So it is in the middle. So you can tell just because of this lateral view, you can see the oblique fissure right here coming down. And you can also tell because you can see the patient's vertebrae right here. And you can see the chest wall and the sternum right here. So that's explaining to me that it looks like the problem is more anterior. And if the problem is more anterior, it's more likely going to be that middle lobe instead of the lower lobe. And so this would be an example of what a localized pneumonia looks like.
Good job, guys.
All right, so what do you guys see here?
So if I were to give a hint, anything that's not dark, there's a problem. If you're looking at the lungs.
And because it makes sense because the lungs are supposed to be filled with air and air comes out dark on an x-ray. So if they're not dark, you can kind of get the hint that it's not great. Oops.
So Akshay actually said COVID.
Okay, so that's correct. This is COVID. So basically you can see just diffuse consolidations all throughout the lungs. So this is not localized to a specific lobe. It's kind of all over. So that's more of a diffuse process. And diffuse just means throughout the whole lung. All right, so this is just another helpful view of the lungs. This one shows really the important impressions that certain organs have on the lungs. So you can see right here, this is what Brendan was talking about with the arch of the aorta. And so you can see this going down, and that has a big impression on the left lung. And then on the right lung, you can see a groove for the esophagus, which is a little bit lower down here. And you can see a big impression on the left lung for the heart. That's called the cardiac notch. So really quickly, we need to get air to the lungs to start with. So how do we do that? So we are starting, we'll just start below the larynx. So we're at the trachea, and there are two specific zones of the tracheobronchial tree. So there's the conducting zone and there's a respiratory zone. So the conducting zone is simply like the highways that the oxygen takes to get to the lungs. So there is no air exchange, there's no diffusion. It's just specifically providing a pathway for the air to get into the lungs. And then you have your respiratory zones, which is where the actual gas exchange takes place. You have the bronchioles and you have the alveoli, which I discussed before. So in here, you can see the trachea comes down and then it actually splits into two main bronchi. And this is connecting back to Brendan. So the point at which it splits into two is called the carina. And it's actually at that angle of Louis that Brendan had talked about first. So it's a great landmark to be able to look at a patient and be able to see that sternal angle or feel that sternal angle and know a lot of what's going on around then. So it's really helpful. So it actually, the trachea splits into two, and there's the left main bronchi and the right main bronchi. And the right is actually, you can kind of see on this bronchoscope down here that the right actually comes off a little steeper and it's wider than the left. And so then from there, the two main bronchi go off to be lobar bronchi. And that is, as their name implies, they supply each different lobe of the lung. So the right is going to have 3 and the left is going to have 2. And then they divide even further into the segmental bronchi. So that's going to split down here. And these are important because you can kind of trace, it's like a trace. So you can trace what areas are going to be served by what bronchi. So those are called bronchopulmonary segments, and those are up here. And you can just see that, like, if you were to be performing a surgery or a resection or anything like that, you would really want to follow these trees to make sure that you're cutting out all of the area that you want to remove. Does that make sense to everyone?
What's up, guys?
Yep. Sorry, Dr. D'Amico. I think we're going to wrap up real quick.
No worries. We're waiting on Dr. Langer anyway.
Dr. Langer said that they could take an extra few minutes if they need it.
Perfect.
Yeah, no, we should wrap up pretty soon. Sorry, Morgan,
Yeah.
it took a while for mine.
Yeah, a couple more minutes and then we can take some questions if we have time.
Excellent.
So this is our last case. It is a 12-year-old boy who came into the ER with shortness of breath after he was chewing on the end of his pencil and accidentally inhaled. And the pencil eraser came off and is lodged somewhere in his tracheobronchial tree. Where do you guys think you would find the pencil eraser? Brendan, do we have any answers?
Yeah, we see some right lower lobes, right side, right bronchi.
Mm-hmm. So why are you guys saying right?
Trust me, when you go into med school and you give an answer, they will always ask why.
Mm-hmm.
I think people are thinking.
Okay.
Yeah, I think we should.
Yeah, we'll just move on.
Because honestly, my chat may have crashed. it's
Okay.
it's a little frozen.
Yeah, I'm a little frozen too. All right, so the correct answer is the right side, because as you can see on this diagram, the right bronchi really comes down at a steeper angle. It's a little wider and a little shorter. So that's most likely, obviously there's always going to be some variation, but that's most likely we're going to find an aspirated foreign body. And I put a link to a bronchoscopy video where you can see the removal of, it actually is a pencil eraser in the video, which is cool, but it's a really cool video. It just takes you down the trachea and through the bronchi. So real quick, this is the last slide, and this is just talking about pulmonary vasculature, which is really a good segue into next week when you guys will be focusing on the heart. So we have pulmonary artery and pulmonary veins, and arteries, as you guys might know, bring blood away from the heart, and veins bring blood to the heart. So your pulmonary arteries are bringing blood away from the heart to the lungs. And this is actually interesting because it's an artery that is carrying deoxygenated blood compared to normally arteries are carrying the oxygenated blood. So in this situation, your pulmonary arteries are going to be carrying your deoxygenated blood away from the heart, and your pulmonary veins are going to be bringing oxygenated blood back to the heart to then be pumped out to the whole rest of the system. Big differences here are that there are 4 pulmonary veins and 2 pulmonary arteries that branch off, and you can see that they're right in front of the trachea. So you can see the relationships between the esophagus, the trachea, and all of the vasculature. Are there any questions on that?
Yeah, my chat's definitely a little wacky right now, so I apologize if I can't see any questions. Joshua, do you happen to see the chat pretty well?
Yeah, I still see it moving.
Okay. Are there any questions that people have?
A lot of like thank yous right now coming in.
Yeah, you're good, Brendan. Marianne and I have been answering some of the questions in the chat.
All right, thanks so much. Yeah, my chat's definitely a little wacky. Yeah, but I hope everyone had fun. It was really fun for me. Sorry, Morgan, I kind of stepped on your times.
Oh, no worries.
But we'll definitely try to coordinate that for next time. Yeah, so next week's going to be cardio. Marianne and Sabrina is going to be taking on that. And we'll see you guys in week 8 when we do the spinal cord. So I'll try to pop in every week and just try to answer questions through the chat. But I hope you guys enjoyed. Any last words, Morgan?
No, thanks, guys. Hope this was helpful for you all.
Thank you
If
guys
there's
so
any
much.
questions, yeah.